Hi everyone, my name is Amy. I'm a student nurse, and in this video I will be talking about breast engorgement with twins by applying the situated clinical decision-making framework. So there's 5 components associated with this framework, and they are knowledge, cues, judgment, decisions, and finally evaluation. So we're going to be starting with knowledge, where we will define engorgement, discuss the pathophysiology, and the causes. So breast engorgement can be defined as the painful overfilling of the breast with milk, often due to an imbalance between the mother's supply and the infant's demand for milk. Swelling of breast tissue occurs because of an increase in blood and lymph supply to the breast due to hormonal changes. One of the main hormonal changes is related to the hormone prolactin, which is responsible for milk production itself. And this hormone increases in the body in high amounts following childbirth. Now, engorgement itself can occur anywhere from 72 to 96 hours after birth and last approximately for 48 hours, peaking between the 3rd and 5th postpartum days. Severe engorgement can actually lead to blocked milk ducts in the breast and lead to infection, which is referred to as mastitis. Also, in severe engorgement, without treatment, the milk-producing cells, referred to as alveoli, can actually shrink in size, and this, of course, compromises milk production just in general. It's important to note that around days 2 to 5 postpartum, a woman will go and start to feel some breast fullness, and this is completely normal. With this normal fullness, the breast and the areola are soft and elastic, milk flow is normal, and latch is unaffected, and this is different from true engorgement, which we'll see later on. Now, I want to think about all this information and how it would relate to a mother who's just had twins. So remember supply and demand as it relates to milk production. It's all about the more the baby feeds at the breast, the more milk is being removed, and consequently more milk will be made. This explains why mothers of twins are able to make enough milk, because now there's extra stimulation of that suckling at the breast since there's 2 babies. And the body can produce that amount of milk that's required. It all ties back to the initial key point that engorgement is primarily often due to an imbalance between milk supply and demand. A mother of twins can just simply be making too much milk. Another consideration for twins is that they are more likely to be born prematurely compared to a single baby, so we want to consider their gestational age related to development. An infant who is born early may breastfeed ineffectively, perhaps because they have decreased muscle tone, they have a tendency, perhaps they're tiring out too easily, or maybe they have a poor ability to latch, suck, and swallow. In terms of causes of breast engorgement, it can occur when a mother is unable to nurse or pump as much as usual. If the baby stops breastfeeding abruptly, so perhaps the baby is starting to consume solid foods, is ill, or just has a poor appetite. If the mother waits too long to start breastfeeding her newborn, or if she's not feeding often enough, or if feedings are too small, or the breasts are not being emptied well, those are some other causes as well. If a woman has sore, cracked nipples, making it difficult for the infant to latch on, thereby again compromising that removal of milk, it can actually make engorgement worse as well, kind of another cause. There's also various factors that affect the effectiveness of infant feeding, such as the gestational age of the infant, the birth history, the history of both mom and baby, sociodemographic factors such as education level of the mother, and personal factors such as the mother's support system. Now we'll explore the second component, which is cues, including the typical signs and symptoms of breast engorgement. So, of course, you're going to see swelling of the breasts. Breasts tend to be firm and painful. Severely engorged breasts tend to be swollen, hard, shiny, warm, and even slightly lumpy to the touch. Nipples can flatten out and the areola can harden. And lymph nodes in the armpits actually may be tender and swollen as well, so it's important to look out for that. For judgment, we want to look at what can be happening for the mother, the baby, and just the overall breastfeeding relationship. We'll discuss the mother first. So, as mentioned earlier, breast engorgement is painful, and the pain will likely result in feelings of discomfort for the mother. The pain can actually hinder the breastfeeding process, which consequently may lead to feelings of frustration, guilt, and disappointment. If the reality of breastfeeding differs significantly from the mother's expectations, she may just have an overall feeling of negativity associated with the entire breastfeeding experience. Now, breast engorgement also affects the baby. Because of the swelling, firmness, and flattened nipples, the infant may not be able to effectively latch, the infant may not be getting adequate nutrition, and in turn may be supplemented with formula. And if they're supplemented, they're missing out on the endless known benefits of breast milk. So how does breast engorgement affect the overall relationship between the mother and her twins, or just that sort of dyad? Breastfeeding creates such a unique bond between a mom and her baby, and engorgement can negatively affect this bond. Skin-to-skin contact may even be compromised. Instead of breastfeeding being positive, enjoyable, and an opportunity to form a special connection, it might instead be tedious and frustrating because of the engorgement. Now, this is where healthcare providers come in. Our role is to support women in the best way possible as they encounter such breastfeeding challenges, perhaps a referral to a lactation consultant or even a physician if the engorgement is very severe, or even considering breastfeeding support groups for the mother as well. So when we discuss priorities, we'll elaborate on the 3 key points using the 3 rules, which apply to most breastfeeding difficulties. So our first priority is Rule 1, which is to feed the infant. We want to ask, are they getting enough food in relation to their age and weight to thrive? And we want to help the infants feed better by increasing frequency and duration of feeds, improving their latch, encouraging skin-to-skin contact, breast compressions, helping the mother identify hunger cues, expressing milk, as well as just educating the mother about breastfeeding benefits, how to maintain her milk production as well. Priority 2 relates to Rule 2, which is to move the milk. So we want to see if we can help the infant increase their demand by feeding more frequently, more effectively. So similar stuff applies here, like we mentioned in Rule 1, but we want to see if milk can be moved via hand expression or use of a breast pump. Hand expression can actually protect the mother from engorgement, plug ducts, and mastitis, and can positively impact her milk supply by establishing it early on. In the case of breast engorgement where the twins are unable to latch, expressing and pumping is a good way to replace feeding at the breast. The third priority is to help the dyad learn to breastfeed. So here, we want to help the mother and her twins breastfeed. So we want to accomplish this by helping with the techniques of latch. So I'll just show a picture here of some common positioning, just some common ways to position mom and her twins, some common breastfeeding positions here. Encouraging the mother to start with skin-to-skin contact, ensuring the infant is calm and starting to wake up, and feeding during then, which is called the quiet alert state, the optimal state to breastfeed. And informing the mother to settle the twins before trying to feed them, and creating a positive environment and recognizing hunger cues can also facilitate that relationship. So for the fourth component of this framework, decisions, we'll look at treatment. So for treatment, we want to look at increasing the flow of milk from the breasts. So this can be accomplished by frequent feedings, ensuring the babies are latched on well as well. Some women will use warm compresses to soften the nipple and the areola before feeding. Gentle hand expression or massaging the breast to promote the flow of milk is useful. Cold compresses to reduce that swelling and relieve the pain. Could be a gel pack, ice gel pack, could be even a bag of frozen vegetables. Instructing the mother to avoid wearing constricting bras as they can actually decrease milk through the ducts and lead to blocked ducts. Applying cabbage leaves to the breast. There's minimal research on this, but there is some evidence that it works for moderate to severe engorgement. You can leave them on for about 20 minutes, no more than 3 times a day, because you want to keep in mind to limit their use, because cabbage leaves actually can decrease milk supply. Non-steroidal anti-inflammatory drugs such as ibuprofen can be used as well if advised by a healthcare provider to relieve that pain and inflammation. And in terms of nursing support, just to act, the nurse can act as a resource, right, as a source of information, assessing each situation uniquely based on the family's needs, gearing those interventions based on the specific case at hand, as engorgement can present differently for everyone. And the nurse must support the breastfeeding woman in her journey as she tries to overcome this challenge. So finally, evaluation. We want to examine if our care has been effective and if the information has been received and understood. So does the mother understand the main causes of breast engorgement as they relate to prevention of this breastfeeding challenge? If breast engorgement were to occur, is the mother able to identify typical signs and symptoms? And is the mother able to identify different treatment methods, including ways to relieve engorgement at home, along with how to seek out the appropriate support from a nurse, a lactation consultant, or even a physician? So in conclusion, this video discussed the breastfeeding challenge of breast engorgement with twins by using the situated clinical decision-making framework. We looked at the pathophysiology, causes, signs and symptoms, judgments around what could be happening, and identified the 3 important points: to feed the infant, to move the milk and to help the dyad learn to breastfeed. We also looked at treatment options, nursing support, and ended off with tying everything together by evaluating the care provided. Thank you.